everyone. Thank you for joining us for this webinar on navigating the transition, unlocking value-based care in rural communities. I am Cassidy Avila, and I'm the program coordinator for the Texas A&M Health Rural Engagement Program. Just a couple of quick housekeeping things before we begin. We are recording the webinar, and we'll make a copy of the recording as well as the slides available soon through a follow-up email from the Rural Engagement Program. There will also be time for Q&A at the end of the presentation. If you would like to drop any questions into the chat box during the presentation while they're fresh on your mind, please feel free to do so. I'll also make sure our speaker sees them during Q&A, and also feel free to save them until that time. That's fine as well. You also have the option to unmute and ask your question. If you want to drop a question to the chat, you can find the chat box at the bottom toolbar of your Zoom window. Click on that drop-down arrow and select everyone or select my name. Either will work. And lastly, we will have a short poll that launches at the end of the presentation. If you would be so kind as to fill that out, we would be grateful. And so now it is my pleasure to introduce our speaker. Rayann Davis is the Director of Value-Based Care at Texas A&M Rural and Community Health Institute. Rayann oversees the population health team that supports the transition to value-based care for rural healthcare providers in Texas. She works collaboratively with rural providers and hospitals offering services that empower and strengthen their value-based care operations and expertise. Rayann has over a decade of value-based care executive leadership experience, including operating clinically integrated networks, accountable care organizations, leading network operations teams at management service organization in Medicare Advantage and commercial, and operating a high-performing provider network in risk arrangements. And I think we have your slides up now, Rayann, so thank you, welcome, it's all yours.
Well, thank you, Cassidy, for that introduction, and thank you all for attending. I look forward to our conversation today. I'm going to start out with kind of the national landscape of value-based care and the different alternative payment models, and then dive a little bit more into the levers to be successful in value-based care and how that translates to the rural communities. So as we go through, why are we talking about value-based care? Why are we talking about alternative payment models? Well, U.S. healthcare spending has grown over 4% and has reached $4.5 trillion in 2022. Nationally, health expenditures account for about $13,500 per person. So each person is spending on average $13,500 annually. We have continued to see an increase in the gross domestic product that's devoted to healthcare. 30% of that cost is hospital care. 21% of the cost is Medicare, and that will continue to grow and skyrocket as you see our aging population in the nation. And then on average, the average household continues to spend more and more on health insurance and health care. We've seen a 7% growth in household spending year over year. And then when you compare U.S. to other nations, across the world, GDP usually ranges about 10 to 12% in healthcare, where we're almost at that 20% mark. And with our high cost of spending, we don't have better outcomes. We have the highest rate of people with multiple chronic conditions. Obesity rate is nearly twice average of the other countries. And Americans see physicians less often than people in other countries. So that is why we've kind of seen this change to value-based care. Before we jump into what is value-based care, this is a very high-level funds flow model example, so there's a lot of nitty-gritty missing in this, but just to be very simplistic in that as a member, you elect a health insurance, whether it's through your employer or your Medicare or the exchange market, you're electing that health insurance, and then that health insurance, whether it's through Medicare, which is CMS, your employer, or state funded, those funds flow to the payer that's overseeing the health insurance. And then from the payer perspective, they're providing payments to the providers. So historically, our health systems, healthcare has ran on a fee-for-service payment transaction where the payer is providing the provider's payments based on the services rendered. So it's very transactional in state. Value-based care really kind of kicked off in 2010 with the Affordable Care Act, where this act created the Shared Savings Program. It created the CMS Innovation Center, establishing that CMMI. And since CMMI, its goal was to create these alternative payment models to achieve the triple aim. That triple aim is increasing quality, reducing cost of care, and increasing patient experience. And over the years, now that we've been in this value-based care journey for 14 years, we've seen over 50 different alternative payment models tested that are looking to achieve this triple aim. The Medicare Shared Savings Program launched in 2013 as part of a regulatory program. And in 2030, most recently in 2030, CMS announced that its goal is to have 100% of traditional Medicare beneficiaries and the majority of Medicaid beneficiaries in some accountable care relationship. That's only 6 years away. That's a pretty aggressive goal, but if you are not in value-based care today, this is a great point to start because by 2030, 100% will be in some sort of accountable care. And then lastly, I want to mention throughout this journey, the triple aim first was introduced in 2010 with the Affordable Care Act, but it has evolved over time. Some even call this the quintuple aim now, which takes into your clinical outcomes, your quality, your patient experience, your providers, but it adds on provider satisfaction and adding on health equity. In addition, these most recent years, also environmental sustainability has been added. So there's the 7 goals of value-based care and creating alternative payment models. I wanted to kind of look at healthcare industry and then some other industries that have seen changes throughout history. If you remember, well, if you look at the transportation industry, it was primarily horses back in the day. And then the automobile came around. When Henry Ford's lawyer was wanting to invest in the Ford company, he advised the horse is here to stay, but the automobile is only a novelty or a fad. So he's going to invest $5,000 and was told not to in the Ford automobile industry. Guess what? He did it, and then later sold his stock for $12.5 million. So when value-based care first was introduced, there was a lot of skepticism if this was the right path forward. And now, as you're going to see throughout the presentation, 60% of healthcare payments are now tied to some sort of alternative payment model or value-based care. So it's definitely transitioned from a fee-for-service model to a value-based care model. Just like the horse transitioned to the automobile, cars replaced horses as a standard within 10 to 20 years. So if you think about healthcare and value-based care, it's been around for about 14 years since the Affordable Care Act. So we're right in there. And then with the accelerated innovation of all the industries, I think we're going to see that skyrocket even more. And if we don't continue to look at ways in which we can be on this path of transition and transformation, we might become obsolete, like several other industries with the innovation have become obsolete. So let's talk about how value-based care and alternative models work and how can we take action today so that we're not left behind. The alternative payment model continuum is vast. Like I said, there's over 50 different alternative payment models just in the Medicare space. Some of these models look at certain health conditions like end-stage renal disease. Some are very care episode, like joint replacements. Some are more specific to provider types like primary care and the Medicare Shared Savings Program. Some of them are across the board, total cost of care, and bringing a network together to manage that total cost of care. When we look at the continuum here, transactional payment is that fee-for-service model. Then we step into quality and outcomes. So programs like pay for performance, patient-centered primary care, PCMH, they provided incentives for doing well in your quality measures. It's still based on a fee-for-service structure, so you're still getting paid traditionally, but you're getting incentive bonuses for better outcomes. Then if you transition over to shared savings and shared risk, this takes into the factor of cost. So you're looking at quality, patient satisfaction, and cost of care. That is a shared savings, shared risk model. And then if you move all the way across, you have capitation and bundled payments, where it's not built on a fee-for-service model. Usually that's a payment that is not transactional based like fee-for-service. So we'll get into a little bit more details of examples of each of these different buckets of the alternative payment model and what that really means. But I wanted to pause here too, if you don't mind chatting, if you're a provider or in healthcare space, where are you at in this continuum? Are you in some sort of pay for performance and quality? Are you taking on shared savings that take on cost? Are you in a capitation bundle arrangement? I would love to see what our audience experiences in value-based care. Thank you for chatting. So when we look at these models, again, for calendar year 2022 payer data, like I mentioned earlier, 60% of payments are in some sort of alternative payment model. 40% are strictly fee for service. So we've gone over and now have more healthcare services connected to a value-based care model. Pay for performance. Pay for performance is really that payment that incentivizes quality and improvement and care coordination. Some examples of quality measures are very much preventative and chronic care management, and primarily primary care focus. So you can see some measures there as examples. These are contracts where you're still getting your fee-for-service rates, and then you receive additional incentives for those quality measures. Shared savings and risk take a population and they look at the historical cost of that population and the risk of that population. And based on that population's history of spending in healthcare, they create a cost benchmark. Then the provider network is looking to achieve shared savings, meaning that the healthcare cost of that population is below what historical trends are for the population. So you're spending less annually on that population and still performing well in quality. And if that's achieved, then that savings is split between the payer and the provider. Shared risk means that, let's say you have a certain benchmark of cost for your population and your population spends more than that benchmark. If you're in a risk arrangement, you could be liable for those costs that are over the benchmark and paying back to the payer. And then I wanted to kind of get into capitation too. This reminds me of a gym membership. Memberships, you sign up to join the gym, you pay a monthly rate, regardless of how often you use the gym usually. And so if you're like me, you'll sign up for the gym, go be really good going to the gym every single month for maybe 3 to 6 months. And then you kind of fall off your ways and you're still paying that gym membership regardless if you go or not. So in capitation, that's very similar model where it's a prospective payment up front for services. So it doesn't matter how much services are rendered, it's a set payment up front on usually a monthly basis for a certain population. So in this example here, you can see 5 different patients. They utilize healthcare differently, but a provider would receive a certain payment for each patient every single month, the same payment. And we refer to this as a per member per month payment. This could range from different provider types, whether that's primary care, specialty, imaging, lab, even inpatient could be on a capitation basis. This is a stable set of revenue for the healthcare providers, but you also want to manage the population. If you're managing the population being preventative with that population, then you're going to prevent future utilization. So in capitation payments, you still have to manage your population so that you reduce the cost of care for that patient population. So I'm going to put this all together. An example of going to the grocery store as one example and creating a budget, because this is all really about that funds flow and cost in a budget based on a population and the quality of care of the patients. So if you go to the grocery store, I'm going to pause here. Do you create a budget? Or are you just going in there and selecting and buying items that you need? If you don't have a budget and you're going in there and selecting all the items you need and you go to the cashier and you check out, you really don't know how much you're about to spend. You might have a rough estimate, but you don't know the full total. This is a fee-for-service model where you're getting services, but you don't know the total amount. You're not monitoring the total budget for that patient population. If you do have a budget when you go to the grocery store, or let's say a different example, buy presents, and you come in right at target, so you go to the cashier, you check out, you hit your budget exactly, that's great, you're right on target. If you come under your budget, that means you have savings, so you can take that savings, put it in your savings account, or maybe go get a little something extra for yourself. That's a shared savings arrangement in healthcare. If you go over your budget, well, you get to the checkout, you still have to pay for all those goods and services. That's a risk and capitation model. You're at risk and you have to pay for those additional services. Just as if you went to the grocery store and checked out and you're over your budget, you're still paying for those items before you leave. So I hope that puts it all together in kind of that continuum of value-based care and alternative payment models. It does vary based on different payers, different programs, but really the name of the game here is that we've transitioned from fee-for-service to now these alternative payment models for healthcare. And it'll continue to evolve as we grow in healthcare and as we find new ways to be efficient and new technologies to be efficient and improve quality of care. So how do you participate in these models? I'm going to give you an example of accountable care organization. And the next slide is going to go over several other network examples. Accountable care organization is an organization or entity that brings together multiple provider groups. So you have these networks of provider groups that then will participate in these value-based care programs and alternative payment models. This helps create a larger patient pool and patient population. It also helps align goals across different provider types. So you might have an entity, a network that brings together your primary care, your specialist, your lab, your imaging, the whole continuum, so that everyone's aligned in that goal of achieving the triple aim. Accountable care organizations usually are more specific to the Medicare Shared Savings Program. And if you need more information, really right now is the time to join an ACO if you're not part of an ACO. If you want to be in a Medicare Shared Savings Program for 2025, that application period just opened yesterday and it closes August 1st. So you have some time to kind of decipher and decide if you want to join an ACO for Performance Year 2025. But that ACO brings together all those tax IDs, all those participant groups. And this is also a way to maintain independence so that you do not have to be part of an employed group. The ACO then contracts with CMS for the Shared Savings Program. The ACO is normally led by a clinician governing board. So the participants will be selected to be part of the board. And then the patient population that's monitored under this alternative payment model is a patient population that those participants are seeing. So as a primary care provider, your Medicare panel will likely most all be attributed to that ACO, and it brings together a larger patient population. So it reduces the variability in costs, because if you have a small population and you have one or two patients with a catastrophic incidences, then your healthcare cost is going to skyrocket for that small population. Whereas if you have a larger population, those one or two catastrophic patients won't break the bank or the budget per se. So an ACO is an example, one example of provider networks, but there's several other different methods to participate in alternative payment models. And some of you might already participate directly with like a Medicare Advantage. If you are participating in Medicare Advantage, they usually have a quality program that's run directly between you as a provider group and the Medicare Advantage payer. But there's networks that can also bring together different groups so that you can go into these shared savings type of arrangement, like an ACO, a clinically integrated network, a risk-bearing organization, or a managed service organization, or like a provider hospital organization, a PHO, or an IPA, independent physician association. Like your PHOs, IPAs are usually your contracting bodies that you're already participating with. A clinically integrated network takes one step further and is taking on more of that value-based care alternative payment network. So you have the payer contracts with the provider network entity, whether that's an ACO, CIN, and then that provider network entity contracts with the different provider participants. And this is creating that pool of patients in these programs. Not every provider network is created equally. You have some models where they will provide lots of different resources for you to be successful in value-based care. And then you have some networks that provide the bare minimum, and it's up to the provider to resource the work that needs to be done to achieve the AAA shared savings and risk arrangements. Okay, I'm going to go into what are the levers to success in value-based care, but I'm going to pause here. Cassidy, are there any questions?
Not at this point.
Okay. All right. So how can we be successful in value-based care? Where do you even start once you do get a contract, once you're in this network? When you think about the pool, your pool of budget of monies that you can spend on your population, that's budgeted for your population, you have different mechanisms in which you can increase the funds flow into your budget for the population. And then you have different mechanisms in which you can manage the medical expense. So these three mechanisms are primarily the trends and how you can increase funds flow to manage a population. If you're increasing your panel size, so the more patients you have, the more budgeted dollars go into your pool for that patient population to spend on healthcare. Improved quality performance. So if you improve your quality performance, you get additional incentives, dollars to manage that patient population. An example of this is Medicare Advantage and the star rating. The star rating is associated to quality measures. So when you think of Medicare Advantage, they're usually on a 5-star rating. And if that Medicare Advantage plan receives a 4, 4.5, or 5-star rating, they receive additional dollars to manage the patient population. Accurate risk score capture of the patient population. I'm going to talk about this a little bit more as we get into the presentation, but this is really looking at the risk of that population and utilizing healthcare dollars. So do you have a high-risk population that spends more on healthcare? And if so, then you're going to have more dollars allocated for healthcare expenses for that population. If you have a lower risk population, then you're going to have lower dollars allocated for that patient population. And then the other two big ways on managing medical expense, these are very large, broad buckets. There's different ways, different mechanisms to manage medical expenses. But broadly speaking, I wanted to call out that payers have methods in which they're managing their medical expense. And then you have your providers that are putting in initiatives to manage the patient population. So payers usually will manage medical expense through contracting rates, through creating these alternative payment models. They'll look at their benefit design, the formulary design. They'll usually have utilization management like authorizations and case management teams doing outreach to improve outcomes. And then on the provider side, it's really about putting in initiatives that help the patient population throughout the continuum of healthcare get the right care at the right time at the right place. So coordinating that care, looking at preventative care, and managing those chronic conditions once they do occur. And as we talk about the value-based care journey and the different initiatives that you can put in place to manage your population, it really is this kind of staircase approach, stair-step approach. You don't need to build all the infrastructure and have all the right initiatives in place before beginning your value-based care journey. You usually, just like there's a continuum of the alternative payment models, you start with pay for performance. You usually put in infrastructure in a stair-step method so that you can grow and evolve and more patients become part of your value-based care journey. So you start with your contracts. You learn about value-based care. It's kind of that culture change from your fee-for-service now to more proactive, preventative, longer visits. You start to look at your risk score capture. Are you capturing the risk of your population? Making sure your patients are coming in annually, looking at those quality measures. And then you start to look at the continuum of care where you're looking at transitional care management and remote patient monitoring, and you can continue to build out your chronic care management strategies. So as we look at this, I really think you have a kind of a four-coined approach on the top of value-based care, and that's where you start. And then you'll start to build out that under the iceberg underneath to help manage the population in their journey in healthcare across the continuum. So the surface, at the surface, starting with quality, measuring of quality metrics, and it doesn't have to be all the quality metrics at once. I would choose a couple and focus on those few, become well-versed in them, do really well in them, and then add more. Patient satisfaction, this is key to the whole journey of value-based care. Making sure that you're monitoring your patient satisfaction, risk score capture, that's really diagnosis code capturing, and then annual wellness visits, making sure your patients are coming in annually so that they are getting those preventative services. And then under the iceberg really gets into those nitty-gritty activities as you evolve into value-based care of chronic care management, transitional care coordination, remote patient monitoring, looking at those social determinants of health, network integrity, making sure that they're going to the right network of providers that are aligning with your goals, reducing preventable and avoidable ER utilizations, decreasing readmissions, and post-acute care network, finding that preferred partner for post-acute care. And you really can't do all of this without the care team model. You need that additional assistance. And as you grow your value-based care populations, you should start generating some of those incentives, which will then help create resources for staffing. And like I said, if you join some of your networks, like an ACO CIN, they might have a care team model for you. And this has evolved where there are ways you can get paid for like chronic care management and transitional care coordination. So you can get paid for these activities from the payer as well. So I'm going to just go into those four kind of overarching given the time frame that we have today. Improving quality performance. The challenges are measuring the measure complexity, and the measures may change every year. The thresholds of performance will continue to change every year as the industry continues to improve. Patient engagement, this is one thing we hear a lot from providers, that the patients are refusing to get X, Y, and Z done, or we put the order in for mammography, patient doesn't want to go. So there's patient engagement is a key to performance improvement. And then the supporting infrastructure and reporting. We are really driving the trend in quality is quality reporting that's electronic, where it's not a manual abstraction of charts. And to do that, you must have the infrastructure to report those electronic clinical quality measures. So those are some of the challenges facing the industry. I would say also the measure complexity, that every payer likely has a different set of measures. So if you have multiple different payer contracts through Medicare Advantage, Medicare, commercial, Medicaid, you might start getting a long laundry list of measures, and it might seem overwhelming. That's where, if you look across your payers, which measures might hit all payers or might hit most payers, and just focus on a couple of those at a time. And you'll see improvement over time. So strategies, again, kind of that payer agnostic approach. Multidisciplinary teams and best practice workflows. There's lots of different best practices out there, and new emerging tools that really are extracting a lot of this data out of your EHR, because it's buried in there somewhere. You're providing that quality of care already. It's just getting it to being surfaced and reported. Rural providers and improving quality. I took a look at some of the diabetes management and compared some of the statistics from rural versus urban. And you'll see there the rural in the light pink and kind of that lighter gray color over the years. So those two bottom lines, light pink and light gray, rural providers have closed the gap with urban providers. You're getting very close, and your rate of improvement has drastically increased compared to your urban counterparts. So rural providers are improving quality, which is very exciting and great for our rural communities. Also, they're the leaders in patient satisfaction, which isn't surprising coming from a rural community. Is that sense of community and being there in the community with your provider. But when you look at patient satisfaction in rural providers versus your urban providers, you are leading the pack in all the different domains of patient satisfaction. And I will say also on rural providers and improving quality and going into shared savings type of arrangements, from 2022 to 2023, there was a substantial increase in rural participation in shared savings. And even from 2023 to 2024, I think it was like 25 to 30% increase in rural providers participating in a shared savings model. So definitely rural providers are starting to transition to value-based care, and it is happening. If you're not starting and would like to start, we are happy to be a resource to help. And if you're in your value-based care journey and need additional assistance and looking at strategy, we can help in that endeavor as well. And then lastly, that risk score piece. A risk score, if you don't know what a risk score is already, it predicts the individual's member expenditures relative to the average member. So it's looking at how much is this patient going to utilize healthcare services versus an average patient. And it's looking at this by considering several different factors. One of those factors is based on your ICD-10 coding, so your diagnosis coding. And this has to happen on an annual basis. Each calendar year, the diagnosis codes for that patient are considered to determine the patient's risk of healthcare utilization. So it's important to code annually, and this is one of those reasons connecting to that Medicare annual wellness visit or an annual wellness visit, that you're able to capture all the diagnosis codes of those chronic conditions. But it must be something that's supported in the documentation and something that's being addressed at that visit. So a 1.00 is an average risk score. So that's an average patient population of their healthcare expenditures and risk. If you're below 1, then you're lower risk, so you're healthier. It represents a healthier population. You're less likely to spend more on healthcare. If you're above a 1, then you're at higher risk and represent a sicker patient population. So we've talked about, kind of hit on each one of these ways to increase the funds flow, risk capture, improved quality, increasing your patient panel size, but then managing medical expenses, care management services. It's really that care team model. There's several challenges in this model as well that in the rural settings are very much present, if not more than your metro counterparts. So staffing and resources is definitely a challenge for rural providers, technology and data infrastructure, and patient engagement. Strategies to overcome these challenges is identifying your population and your goal. So look at those populations that are aligned to some of the incentives and start there. Start small and take advantage of some of those payers that will pay for these services, so that they're billable services as well. So it helps create a quicker ROI on the staffing resource it takes to do care management. Look at partnerships. So look at community-based organizations, other types of community organizations within your communities that could help potentially manage your patients or engage with your patients in their healthcare journey, and bringing it all together with a team approach. So yeah, going back to those community-based organizations that could help with some of those social determinants of health is key. And I think partnerships too, finding the right network to be with that can provide some of the resources in your care management services. So I mentioned the billable services, Medicare billable services. RHCs and FQHCs as of January 1st can now bill for all these different chronic care management services. I think we mentioned this in one of our earlier webinars as part of the Rural Health Engagement Program. There is a whole set of new acronyms RHCs and FQHCs can take advantage of and bill now. So this will help create some of those revenue streams to help staff the services. And we're adding to the acronym soup. Bringing it all together, alternative payment models are really that method in which we are connecting outcomes to payment, providing care for the individuals that is coordinated across the continuum and helping them in their healthcare journey. Being in healthcare, you know how you have insight in how complex healthcare can be. And for those that have never experienced or been part of the healthcare industry, it's even more complex. So helping our patients navigate the continuum and get the right care at the right time is key in these alternative payment models. Some of the trends that we've seen in the last few years is a growth of these provider networks, these networks merging together to become more of a nationwide provider network. So you might be part of an ACO that crosses multiple different states. There's now more opportunity to get upfront investment payments to help source these initiatives. There's new billable services. There's new rural enablers, so new partners in the industry that can support you as a rural provider in value-based care. And a lot more innovation around the customer and consumer, engaging them in technology. I did want to, as we talk about value-based care and alternative payment models, just call out Medicare Advantage, as they are one of the different alternative payment models in the Medicare space. So Medicare Advantage, patients can elect to be part of Medicare Advantage instead of traditional Medicare. And in the rural space, this has pretty much quadrupled over the last 10 years, 14 years, at a rate that exceeds metro areas. So if you are in Medicare Advantage space and you have that high penetration of populations, there are ways in which you can get incentivized for these quality measures and be a part of their quality programs, or be in a network that's taking on shared savings type of arrangements. So if you need assistance in this type of contracting, looking at your performance, understand what's your biggest opportunities, we can help in that endeavor as well. So as part of the Texas A&M Health Rural Engagement Program, we have value-based care consultative support. That's more consultation on the ground, where we're helping you through these contracts, through these arrangements, create financial modeling of the opportunities, create initiatives, provide support of creating the initiatives, and looking at strategic planning of how you can grow in your value-based care journey, where you start, where you are now, and where you want to be in the future. We also can help in the deployment of chronic care management and remote patient monitoring. So if you're not doing that and you're interested and you want to kind of know where to start, we can help in that endeavor as well. So if you're interested, this is a free service as part of the Texas A&M Health Rural Engagement. So it's free to you all. And if you'd like to submit an inquiry form, you can do that via the QR code. I believe it's also going to be sent out after the webinar in the email. But I think I'm really good on time here, so we have some time for questions.
Yeah,
I'll pause there.
Yeah, absolutely. And Rayann, I did just drop that link for TA support in the chat. So if you can use her QR code, you can email Rayann, or you can use the link that I just sent out. That was excellent, Rayann. I'm going to go over to the chat and see if we have anything. I don't see any questions yet. So this is your opportunity to go ahead and form your question, drop it into the chat. You can unmute yourself and ask Rayann directly. And we do have a couple of minutes, so you have time to kind of think of those questions. And I'm going to make a couple of announcements and comments. As Rayann said, her support is at no cost to rural providers in Texas. So if you want to kind of get more information on that or request some support, please do reach out to us. I will also drop the website link into the chat where you can read a little bit more about the technical assistance that she's able to provide, as well as other consultants at the Rural Engagement Program. So those two links are in the chat for you. Let's see, let me double check again.
I will add our next webinar next month. We'll go over chronic care management and remote patient monitoring. So if you aren't, you'll see registration links come out from that. And if you have more questions around value-based care or would like to see different information presented, please let us know. We have our July webinar will be around value-based care as well. So if there's something you'd like us to dive a little bit deeper into, happy to get those suggestions.
Yeah, absolutely. I still don't have questions in my chat, so I'm going to go ahead and launch a very short 4-question poll if you have a moment to complete that while we wait for anyone that might be working on a question. But we appreciate your time today. And as Rayann said, this will come out in an email, and we'll have a link to the recording a link to download the slides, and then some information about our upcoming June webinar. And as Rayann said, this is the first in a 3-part series around value-based care and chronic care management. So be sure you get registered for that one as well. And thanks to everyone that has submitted that poll already. Thanks for the comment, Diane. That's very kind. We were glad to see you on today. And great. Okay. Rayann, I do not have any other questions in the chat at this time, but we do still have some people on and completing the poll. So we'll just hang out for a few minutes. Let's see something. Thank you too, guys. We appreciate you.